Hello everyone, and welcome to the Fifth Estate, our fortnightly forum here at the Wheeler Centre and our podcast as well. It's just a great pleasure to be able to introduce Alex Wodak. Alex is the President of the Australian Drug Law Reform Foundation, and he's been the Director of the Alcohol and Drug Service at St Vincent's Hospital in Sydney since 1982.
That's correct.
And he is, of course, a world-renowned expert on drug policy. So welcome, Alex, and thank you so much for joining us here this evening. The reason for the timing for asking Alex here at this time, a report was released a couple of weeks ago, the Australia 21 Drug Report. It was put together following a roundtable of very prominent Australians, including former police commissioners, our current foreign minister. He wasn't, of course, at the time. He was very honest about what he really thought on this matter. Tell us a little bit about this report and its recommendations.
Well, the report itself was stimulated by another report from the Global Commission on Drug Policy, which is a group of about 20 very prominent leaders from around the world. So that group includes 4 former presidents of Brazil, Colombia, Mexico and Switzerland, Sir Richard Branson, Javier Solana, the former EU Foreign Secretary, people of that kind of stature.
Kofi Annan, I think, was
Kofi Annan, George Shultz, former US Secretary of State, and also Paul Volcker, the former chairman of the US Federal Reserve. So people of some considerable stature. And they put a report together and held a press conference at the Waldorf Astoria in New York on June the 2nd, 2011. And they said in that report that that it was clear that the war on drugs had failed, and it was really time to have an international debate about what to do next. There's more to it than that, but that's essentially what the report says. And I attended one of the sort of planning meetings of several members of that group in Geneva in January 2011. And so that Global Commission report stimulated Australia 21 to go back to the issue of drugs and hold this round table where there were 24 people present. About half, maybe more than half, were senior retired politicians, and other people were clinicians, researchers, drug law enforcement people like that. And the meeting was held under Chatham House rules, so I'm not supposed to say who attended and what an individual participant said. We're allowed to quote what people said in principle, but not identify who said it. Some people have outed themselves and are comfortable doing that, but the participants are not supposed to do that.
Doesn't it tell you a lot that people feel they're outing themselves and even talking openly about this?
Well, there in fact had been several previous meetings at Chatham House in England on this subject, which several of my friends have attended, and they were, as I was, they were stunned to hear people of such high rank in our community saying so unambiguously that the war on drugs had failed. These are people who would have defended the war on drugs in their professional jobs previously when they were serving politicians. And some of my friends said to them at these Chatham House meetings, well, why do you say this now here and you don't say this when you're doing your UN or European Union jobs or whatever you're doing? And they said, well, you know the system. The system is that when you are in the system, you can't undermine it. You have to follow sort of cabinet solidarity. But if you want you guys outside the system want things to change, you have to bring the system down.
So Juliet Gillard's response to the Australia 21 report, which really reflected the global findings, the devastating failure, in fact, it says on the very boldly on the front page, the prohibition of illicit drugs is killing and criminalising our children, and we are letting it happen. Julia Gillard's response was just a blunt no to any kind of softening, to any notion that decriminalisation or other changes in drug policy might be even worth examining. She didn't even offer to consider the recommendations, neither did anybody on the opposition. How do you explain this? How can a report like that be just discarded so cleanly and left?
Well, it's a very difficult issue for politicians. It really is. They feel they can't win. Whatever they say is going to be vilified. And to be fair, the opposition leader, Tony Abbott, said something that's virtually the same. And Nicola Roxon said a variant of that, not quite as bad. Mark Butler, on the other hand, who's responsible for this area, was much more open-minded. But it is very difficult for politicians, and Barack Obama's doing something much more serious on a much bigger scale. He said in the Senate, the US Senate, in 2004, when he was a senator for Illinois, he said that the war on drugs has failed. I can't remember his exact words, but they're not at all ambiguous. They're very clear. And now he's playing the game in the lead up to the 2012 elections in November. He's playing the same business of trying to pretend that he's a supporter of the war on drugs. And the Justice Department is chasing the issue of medicinal cannabis in the United States and at the state level. So there's and it's clearly being done for political reasons. So I'm not really surprised at all by the Prime Minister's reactions. Of course, I would have liked them to be different, but I think we have to be realistic. The politicians are going to be carried kicking and screaming across the line on this issue, as they are, unfortunately, on many other similar kinds of issues like marriage equality. And there is a lot of similarity in that. The young generations in Australia just don't understand why this debate on marriage equality is even taking place. And likewise, the young generations just don't understand why in 2012 we're still trying to deal with this nonsense.
You're a practising doctor at St Vincent's in Sydney. Can you tell us a bit about what you're seeing? You've been there for decades. How drug use, drug patterns of use, who's using, how has that changed over the time you've been there? What are you actually seeing?
Well, I work in a very large hospital close to the biggest drug market in the country. And so we see a lot of people who have serious medical and mental health problems resulting from drug use, and also people who are very badly damaged in many other ways as well. It's not pretty. On the other hand, you see people who are recovering from all of that process and trying to get their lives together again, and that's very moving. And it's although I've been doing this for 30 years, I'm very moved by it, and I get a lot of satisfaction seeing people in that situation start putting their lives back together again and enjoying their life and making a contribution. I did some of that this morning, and I look forward to doing that.
Are the things that they need and the things that you advocate in policy change the same for all drugs, illicit drugs?
No, it's very different for illicit drugs. I'd have to say that the whole field would have to be the most politicised area of all medicine. Cardiology or endocrinology, hormone diseases. There's no field of medicine that is as politicised as this area. And that has a big impact. And also, it has a big impact on what I do and what other people like me do, in that we are trying to provide health and social services to people who are, as far as the law is concerned, are criminals. And that has a big impact on us. I read last year that when alcohol prohibition was running in the United States from 1920 to 1933, the treatment of people with alcohol problems disappeared in the United States. because of the difficulty of trying to treat criminals. And by the same token, we go through a lot of contortions trying to provide a healthcare service to people who have a health problem. And it's been misclassified as a criminal justice problem. And there are criminal justice elements to it. But unfortunately, it's been labelled as a criminal justice issue. And in Australia, 75% of government expenditure, Commonwealth, state and territory expenditure in response to illicit drugs goes to drug law enforcement, goes to customs, police, courts and prisons. So it's so heavily seen as a drug law enforcement issue that there's very little money in the kitty left for health and social services. So the health and social services that this population gets, frankly, stink. They're really terrible. And anybody who's a drug user knows that that's true. This population is heavily stigmatised, heavily discriminated against, and a lot of that is due to the laws that we have.
Tell me, in a sort of a dream world, what would you like to see in a change of policy? How would it be?
The first step is that this area has to be redefined as a health and social problem, primarily. We'd still keep drug law enforcement, as we do with the legal drugs, alcohol and tobacco, where law enforcement plays an important contributory role. But what we really need to do is redefine it, and automatically that would make a lot of the problems that we have today get much less. We also need to spend a lot more of the funding needs to go on the health and social interventions, treating it like a health problem, as we do with alcohol and tobacco. So that would mean that we'd be able to provide enough treatment for all the people who want treatment. We'd be able to provide treatment that's actually attractive. We'd be able to try and provide treatment that's effective. And we'd have much more flexibility than we're allowed to have when it's seen as a law and order issue. That's really the start of this, setting that kind of a landscape. I would want to see that human rights of people who use drugs are just as respected as the human rights of people who don't use drugs. I'd like to see that we acknowledge that this has got tremendous public health implications, and that gets recognised. That policy, practice and programs would all be based on evidence rather than on ideology, as they often are at the present. In other words, we do things that work. We also invest in things that have a good return for the community, and we don't do that at the moment. I'd also like to see us recognise that while we're dealing with this issue as a criminal justice problem, we're dealing with a drug market which has got very powerful market forces, and at the moment we pretend those powerful market forces don't exist, and we pay a very heavy price for that. So that's really the kind of mental landscape that I think we have to approach this with. And then that leads on to things like taxing and regulating cannabis. So that would mean putting stickers on the packets saying that cannabis may give you lung cancer or schizophrenia or whatever you want to say. Don't use cannabis if you're pregnant, that sort of thing. If you're struggling to stop or quit altogether, ring this number. This packet contains X% of THC and Y% of CBD.
So very similar to the tobacco.
Yes, it should be. Yeah. It should be treated like that. And we would also.
And where would you get it?
I got into trouble for answering that question before, but the principle is that the outlet, well, cultivation, wholesale and retail should all be governed by hard-to-get and easy-to-lose licences. So you'd have to demonstrate that you're a fit and proper person before you're allowed to cultivate or be responsible for wholesale or retail sales. And this is the retail part's what they do in the Netherlands. They have these hard-to-get, easy-to-lose licences that are very lucrative. You're not allowed to sell to under 18, people under the age of 18, and you're also not allowed to sell other drugs. And if they come into your coffee shop in Amsterdam anywhere in the Netherlands and you're infringing those regulations, you get closed down that night with no appeal, and you've suddenly lost a very lucrative income. So the same principle should apply, that we should have hard to get and easy to lose licences. And then I think we've learnt from the mistakes we made with alcohol, tobacco, so no advertising, no donations to political parties, and of course I'd want to see proof of age for people purchasing as well.
So they'd be specialist retail places, or I mean, if it's heroin, amphetamines, those sort of drugs as well. Is it all a sort of under one roof? Is some of it provided by doctors?
Well, I think one area where drug law reformers and drug-free people agree is that nobody wants to see 1 kilogram bags of 100% pure heroin or cocaine sold in supermarket checkout counters. And I don't think that's ever going to happen. I don't think it ever should happen. But there's room for some kind of compromise in the middle there. We have to remember that up until 1906 in Australia, edible opium was sold, taxed and regulated. It was legal. It was banned in 1906. We have to remember that until 1903, Coca-Cola contained cocaine. So we've been down the road before where there's been commercial retail sale of small quantities, low concentration, illicit drugs. And I think we could go back down there as in the future. Before we get there, though, I think...
Without putting the Coke back into Coke, though, I assume.
Well, in several Andean countries in South America, you can buy in supermarkets, you can buy cocaine tea bags, and so you make an infusion of cocaine with boiling hot water, and nobody finds that a problem in South America. So I think we can learn from these experiments around the world. That's going to pick up the edges, but I think the bulk of the drug issue will be picked up by very much expanded, very much improved and much better funded drug treatment for drug users. And at the heart of all of this, we're still going to have a black market. There's always going to be a black market, but if the black market is... who knows what it is in Australia, if it's, let's say it's $2 billion a year, if it goes from $2 billion a year down to $20 million a year, that's an advance, surely. So I think we would see a dramatic reduction in the black market.
A lot of the negative imagery around illicit drug use is on young people and on junkies and just people on the street and so on. But of course we know that drug addicts come in every form. There are pilots and lawyers and doctors and so on. It seems to me, I'm an anthropologist in my background, and I have never been able to find a single culture across time where people in that culture didn't want to take mind-altering substances. But of course, in many of these communities or societies, it was monitored and it was very, carefully organised how things were taken, and people would be watched over and sorts of rituals and that sort of thing. When did we we decide that drugs were simply evil and needed a war upon them? Was it Napoleon or Nixon?
Well, it evolved slowly from a critical meeting in 1909 in Shanghai that was convened by the United States. And that meeting was convened because, for several reasons. One of the main reasons was that the United States Christian missionaries in China had seen the terrible behaviour by the British towards the Chinese in forcing the Chinese to take opium from India. And they did that because when the United Kingdom took over India as a colony, they inherited a problem whereby China was selling to India a lot of silk, tea and porcelain and not buying very much back, and that there was a huge trade imbalance, and China had that huge trade imbalance with many other countries, and as we are very conscious today, huge trade imbalances cause a lot of political tension, and they did at that time too, in the early 17th century. And so the British decided to reduce the size of that trade imbalance, which also affected England as well, by selling Indian opium to China. And so they built up this huge industry, which had really started before colonisation with the East India Company. And they built up this huge industry, which at times paid for 25% of the costs of the British colony in India. So it was very important economically and politically. And they forced the opium on the Chinese, and in the 19th century there were 2 opium wars, and the whole history of Hong Kong and Calcutta is bound up in this history of this relationship between those 3 countries and opium. So the Americans saw all this and were horrified at the appalling treatment of the British to the Chinese, and they convened this meeting in 1909 and started a process, and that led to a meeting 100 years ago this year in The Hague in 1912, and then a third meeting, which was the really critical meeting in Geneva, held under the auspices of the League of Nations. Now, the Americans drove that whole process, and although the Americans didn't join the League of Nations, they attended the 1925 Geneva meeting as observers, but controlled the meeting as observers, which is quite a good trick. And then out of that meeting came a League of Nations agreement that prohibited 3 plant-based drugs: opium and derivatives, coca, meaning cocaine, and derivatives, and cannabis and derivatives. Incidentally, cannabis wasn't on the agenda of that meeting, and there was no evidence presented about cannabis at that meeting, but nevertheless the meeting decided to prohibit cannabis. And so that set up this international system, which grew and grew and grew, and then when the United Nations was established after the Second World War ended, the agreements that had been negotiated and approved under the League of Nations were rolled up into a convention in 1961, the so-called Single Convention, and then 2 other conventions followed in 1971 and 1988, and that's the international legal system. And if your country has signed and ratified those conventions, then your country is required to pass domestic legislation which invokes criminal sanctions for people who cultivate, produce, transport, sell, purchase, possess, consume, etc., any of the following drugs. And then the following drugs are listed, and there's a process for reviewing that list under the United Nations system. So that's how the system works. Of course, it's much more complicated than that, but that's just a quick summary. And then the next real twist in all of this was in 1971, on June the 17th, when President Nixon declared a war on drugs, and that came out of the Committee for the Re-election of the President. Nixon was worried that he wouldn't get re-elected in 72 because of the very unpopular Vietnam War. So John Ehrlichman of Watergate fame had suggested, as a member of CREEP, the Committee for the Re-election of the President, that Nixon should wage a war against drugs so that the elderly, white, wealthy people who voted for Nixon in 68 would vote for Nixon again in 72. It was as blatant as that. And Ehrlichman said all this before he died. And so that was taken to the 72 elections. Nixon won 49 out of the 50 states. And politicians around the world in democratic countries saw that this was the magic pudding that they'd all been waiting for, that if you wanted to get elected and re-elected and were pretty hopeless otherwise, you could say that you'd wage a war against drugs in your country and you had a very good chance of getting elected or re-elected. And that has really continued on for 40 years, and then it was really the advent of HIV infection and the importance of HIV infection among injecting drug users and then spreading from injecting drug users to the rest of the community that made people really wake up that this is a very counterproductive approach. And so in the last 30 years, there's been a growing realisation that drug law enforcement is very expensive, often counterproductive, seriously counterproductive, and is cost ineffective, and that there are much better ways of spending scarce taxpayers' money than throwing it at customs, police, courts and prisons.
You were talking, and I know in all your work, this evidence-based approach is what you continually try and emphasise. There's now quite a bit of evidence coming in from various other parts of the world. Can you tell us where, they might be doing things better or where it's not working, if they've tried to introduce new ideas that haven't worked? Where are they doing it differently and how is it going?
Well, I suppose the first crack in the whole system was the Netherlands in 1972 when they had two commissions. The Netherlands was starting to see the things that have become common throughout the developed world in the last quarter of the 20th century. And so they were seeing drug use in young people in the drug culture, and they didn't know how to deal with this. And so they held these two commissions, which proved to be very influential in setting up the Dutch policy. And then the Dutch were viciously attacked by their neighbours, Germany and France, and also by the United States. And so the Netherlands decided not to continue that reform process. And I suppose the next major change was in Switzerland and then later in Portugal. And in Switzerland, in the late 80s, early 90s, went through a wave of explosion of drug use, probably related to the breakup of the Yugoslav Federation and the breakup of the Soviet Union, and some of the best criminals from both of those countries decided to head for the richest country in Europe and get involved in the drug trade and make a lot of money, which they did. And the Swiss certainly noticed the effects of that. And so in the late 80s, early 90s, a woman couldn't walk near a railway station in Switzerland without getting her handbag snatched. It was really very unpleasant. HIV was out of control among drug users. Drug overdose deaths were increasing and crime was increasing. And the then president in the early 90s, a lady called Ruth Dreyfus, the first female president of Switzerland, first Jewish president of Switzerland, she and her colleagues asked for advice about what they should do about this. And they were told more money for the police, more severe penalties, and the problem would get less. So they did that a few times, and the problems got worse and worse. So then they asked other people for advice, and people said the sorts of things that I'm now saying. And so they started this different approach, funding health and social services much more generously, having more flexibility, starting a heroin trial in 1991. And lo and behold, drug overdose deaths fell, HIV fell, crime fell, and everyone felt very good about the results. Ruth Dreyfus now, 20 years later, is a member of the Global Commission on Drug Policy. She's one of the four former presidents taking part in that process. And then the third major development in Western Europe was Portugal. And Portugal went through a similar kind of process in the late 1990s, and they commissioned they set up a committee chaired by a doctor who'd worked in the drug and alcohol area all his career, and 4 or 5 people on this committee designed a whole system which the Portuguese then debated for a year or two, and then it went through some committees and went through Parliament and was adopted and came into force on July the 1st, 2001. And that's proved to be extraordinarily successful. And essentially what that has done is that if you're caught with a small quantity of drugs, and there are threshold levels for each different kind of drug, and if you're below those levels for each of those drugs, then you go through you get referred to the Commission on Drug Dissuasion, and you go before a panel, and they ask you about your work and your relationships and your bank balance and your commitments, and really whether you're functioning as a member of the Portuguese community or not. And then they make some inquiries and check up on things you've said, and then if it turns out that you're functioning and you're having ecstasy once a week and smoking cannabis once a fortnight and having some LSD once a month, but you're keeping your life together, you're not disintegrating, they say, well, we'll see you in a year or 2 years. And if they see that your life is in a complete mess, they'll make an appointment for you next Monday at the drug dependence clinic, which is well funded and can help you. So it's a health-based, social-based approach.
This was the model that Bob Carr was most impressed with, I think. Is that right?
Yes, look, he's been... He made it clear that he's been torn by this issue. I think people are aware that he's lost a brother under most distressing circumstances, that he saw his parents pained by the fact that his brother was in a coma for many months, and the parents, now very elderly, went into across the road from where I work, the hospice at St Vincent's Hospital, every day until the brother died. And that was a very painful experience for the whole family, no doubt. And it's obviously affected him very greatly. He talks about that quite often. So he said he's been torn by that, and it's very obvious that he's been affected by the developments in Mexico, which are really astonishing and very poorly reported in this country. And it's really those developments in Mexico, Central America and South America that are really driving this debate around the world now, because we see this, understandably, from a developed country perspective. We think of this issue as it affects us as Australians, but really that's dwarfed by the damage this does to the producer nations and the transit countries like Mexico, who really are suffering levels of torment and pain that no country should have to experience on their behalf or on our behalf. It's not something that people really understand, that the people who are producing these drugs and where these drugs are transiting through the country are really paying a price no country should have to bear, and it's because of this global policy. We all know in this country that Afghanistan's got a bit of a problem, and Pakistan maybe, and Mexico, but people don't really understand the enormity of these problems and how it's corrupted the governments, it's made the institutions and the governments completely ineffective, and part of the reason that the drug trafficking got established in those countries in the first place is that the institutions and the government weren't that healthy in the first place. But country after country that's being involved in this, even on a transit basis, are getting knocked sideways. And we see this from a rich country's perspective. We don't realise that the people who are really paying the price for this are the people in the poor countries where the drugs are being cultivated, produced or transited.
What are the changes in South America that are really driving it?
Well, the United States is the biggest market for drugs in the world. They're the biggest consumers of drugs in the world, despite all the hypocrisy of their teachings and rhetoric. They're the big drug consumers. So the drugs, by and large, are produced in South America. That is, the cocaine comes from Bolivia, Peru, Colombia, and a little bit of the opium comes from Mexico, and some of the cannabis comes from Mexico and then from Canada. And the drugs used to transit from South America to the United States through the Caribbean. But the Americans managed after a while to figure out how to slow that passage of drugs down to a trickle through the Caribbean. So such a lucrative crop wasn't going to just sit on the wharves in South America, so it ended up travelling by land through Central America and Mexico. And Central America and Mexico have been devastated by that. And then after 9/11, the Mexican-US border was tightened considerably, and with the tightening of the border, the price differential on the Mexican and US sides of the border has increased, and the greater the difference in price, the more violence. So 50,000 people have been killed since President Felipe Calderón of Mexico declared a war on drugs after his inauguration in December 2006. And the number killed in Mexico has increased every year from 2006. Last year, 2011, there were 12,000 people killed, 16,000 expected this year. And parallel with the increase in homicides is an increase in kidnapping and in extortion. So people like us, who are privileged, well-educated, have a bit of money, are prime targets in Mexico, and people like us in Mexico are absolutely terrified. Several areas in the west, north and in the east, where the drug traffickers are strongest, are being depopulated, and whole towns and villages are now empty because people are terrified to live there. And so it's a shocking state of affairs. The rule of law's really suffered in Mexico. 2% of violent crime, that is severe sexual assault and manslaughter and murder, 2% of those crimes are solved in Mexico at the moment. So you've got a 98% chance of getting away with manslaughter or murder in Mexico today. People are terrified. The traffickers determine who's going to be the next mayor and who's going to be the next police chief. And terrible as the situation is in Mexico, it's even worse in Central America, so especially in Honduras and Guatemala. Horrific rates of carnage are going on there. And of course, where do the guns come from for this? From the United States. And the Americans can't deal with the guns because under the Second Amendment, the right to bear arms, the Americans won't touch the guns travelling south, as they expect the Mexicans and Central Americans to stop the drugs heading north. So this is really the situation in Central America, Mexico and South America now, and half a dozen serving presidents now, let alone past presidents, are now calling for drug legalization, including the President Santos in Colombia, who convened that meeting of the Summit of Americas just 2 weeks ago, and also the presidents of several other countries in that region. Now we've had the Prime Minister of Canada, Steve Harper, a very conservative leader, who said 2 weeks ago that the war on drugs has failed. And so the whole climate internationally, it's not reported really in Australia yet, the whole climate is really changing.
The President of Colombia saying that is extraordinary, isn't it?
Well, Colombia has suffered enormously for this for decades, and they've been troubled by this huge insurgency, a left-wing and a right-wing insurgency that's been fueled by drug trafficking, and they've struggled with that. The Americans have supported them with that, but what's happened now is that they've got the insurgency more or less under control, but it hasn't done anything to the level of manufacturing of drugs, principally cocaine. So there's a little bit less violence in Colombia than there used to be, still unbelievably high by Australian standards. And this really isn't all that surprising, because there are about 20 major studies that have looked at drug law enforcement and violence, and almost all of those studies have found that the more intensively you implement drug law enforcement, the more violent your country will become. It's maybe not what you might think or expect, but this is what happens. And of course, that's exactly what's happened in Mexico.
In Melbourne, it's not even been possible to get a safe injecting room Some of the inner city councils have really tried for this. You were behind the safe injecting room in King's Cross, which I think celebrated its 10th anniversary, 11th, recently. How inflexible is Australia? It seems like there are things happening in Central America and Europe. Why can't we do even that much? What does it take to even get a safe injecting room up outside of King's Cross?
Well, it takes politicians who are prepared to look at this issue logically and rationally and look at the evidence.
That's asking a lot right now, isn't it?
It's asking a lot at all times, especially now. But it's not just Australia that struggles with this. Canada's been very divided over this issue. They've only got one injecting room in Vancouver. There are now two more that are going to go up in Quebec. But the current Prime Minister, Steve Harper, in Canada, went through three major court challenges to try and shut down the injecting room in Vancouver, and lost three times in two appeal courts in British Columbia, and then in the Supreme Court of Canada, where the decision was handed down a few months ago, a 9-0 decision against his government, with the majority decision written by the Chief Justice. I don't know that there could be a more comprehensive legal defeat than that. So it's a struggle not just in Australia, but many other countries struggle with this. But Western Europe is much more pragmatic about this. So they don't have the kind of battles that we've had. England hasn't got an injecting room. They had injecting rooms in the 60s, but they don't have any injecting rooms now. We should be starting injecting rooms in Australia. We don't need them in every suburb, of course. We only need maybe half a dozen or a dozen in the whole country, in parts of the country where we've got our biggest drug markets. And where those drug markets are spilling over into neighbouring streets and lanes and parks and supermarkets, that's where you need a supervised injecting centre. And the one in Sydney is extraordinarily successful. The local residents support the King's Cross Injecting Centre by something like 70 to 80%. And those people who lived there before 2001, when it was established, about 90% of them would support it. So it's very strongly supported also by local business. There's very strong support. But the government has been, both the Labor government and now the current coalition government, haven't been quite so fulsome in their praise of it. Although it was interesting that last May 2011, the then new minister who was responsible for the medically supervised injecting centre said publicly that the debate's stupid, it's gone on for far too long, it's very clear that this works, we don't need to debate it anymore, and it shouldn't be funded from the proceeds of crime as it has been up till now, it should be funded from the health budget. And this is a National Party minister, Kevin Humphreys, and so I think that's cooled down a lot of the debate in New South Wales, but we really should be going on in New South Wales to have a second, third or fourth medically supervised injecting centre, and they're clearly also needed in Fortitude Valley and Brisbane, and maybe Melbourne would need a few medically supervised injecting centres here as well. But the critical difference is approaching this as a logical and rational exercise, looking at the evidence for and the evidence against, and looking at it in that framework. And yes, that is difficult.
I am going to throw it open to questions in just one more of my questions time. In Denmark, Alex, I was listening to an interview of a woman who was at the forefront of changing some of the policy there and introducing a medical model. But one of the things she said, she'd been working for 15 years trying to introduce changes, and like you, she talked about the evidence. She said it was so clear, it was, that the truth was in front of us in statistics, in evidence, but she said we just couldn't persuade the government, we couldn't persuade the police, and that it was actually a terrible and tragic story about a young woman, a 30-year-old prostitute, taking drugs that actually galvanised sort of the whole nation, and everybody kind of seemed to fold together into wanting change. Is it possible that evidence is not going to be enough, and that you need to find something that's just going to shift people's feeling about this?
Well, the evidence ultimately, I think, does overcome fear, which is really what this is all about. And Herb Stein, one of Nixon's economics advisors, used to say, things that can't go on forever don't. And I think that's very true in this area, that it takes a while. You have to be very dogged, very persistent, very patient. And what happened in Denmark was that about 4 or 5 years ago, all 9 major political parties in Denmark decided, they had a meeting and they decided they would all support heroin-assisted treatment. And so they introduced that now. That's like methadone treatment, but for people with very severe heroin problems who haven't benefited from a myriad of other previous treatments of diverse kinds. And so they have prescription heroin, which they self-administer along with intensive psychosocial assistance. And that treatment has been found in half a dozen trials in different countries in Europe and Canada. That treatment's been found to be very effective, very safe, and also cost-effective for that population. And so Denmark is the first country in the world to introduce that kind of treatment without doing research into it. So we hope that other countries will follow, and the evidence was persuasive in the case of Denmark doing that. 9
political parties agreeing on anything is just remarkable, isn't it? Now, if you have a question, just put up your hand and somebody with a microphone will just come to you and place one. Does anybody down the back there? Yeah.
Hey, you talk a lot about treatment, but I'm really wondering what evidence there is that prevention would be higher under your recommended approach.
Well, that's a great question. We have very great expectations for treatment, for prevention around the world, and prevention does work a little bit. It's not very expensive, but it certainly isn't the panacea that a lot of people think it should be. In terms of cost effectiveness, it's been estimated that for every dollar spent, the savings are $1.60, so it's worth doing. But the benefits are not only small, but they're also delayed. So if we started doing good prevention in 2012, it might take 10 or more years before we actually start seeing the benefits of that. So prevention's not the magic, not the silver bullet that we would like it to be. On the other hand, I think more and more people around the world are being persuaded that one of the aspects of this that has really been unjustly neglected is the issue of inequality. And it's clear that in those countries in the world where there are greater levels of inequality in the rich world, countries like the United States and unfortunately Australia, we have much higher levels of drug use and problematic drug use. And in countries with much greater degree of equality, Scandinavia and Japan, levels of drug use are much lower and problematic drug use is much lower. And there's a book, The Spirit Level, that's been written about this and other kind of similar public health changes. But I think one of the things we should be turning to in prevention is the question of how unequal do we want our communities to be, because I think that also has a bearing on prevention.
Hi, you spoke about the dramatic 70 to 80% turnaround in public opinion about the legalised shooting up institution.
Medically supervised injecting.
Medically supervised injecting room in King's Cross. What are the qualitative differences that sort of sparked that turnaround in public opinion? actually in the community of King's Cross? And do you think that is hinged upon the psychosocial sort of monitoring systems they've got in place and the paramedics they've got within the supervising rooms?
Well, I think it's not surprising at all, because we're talking about an area that's the biggest drug market in the country, where it's the most densely populated part of Australia, and where local residents were used to the fact that when they were going to the supermarket to buy a litre of milk and coming back, that there was a chance that there'd be a dead body in the street from a young person. And people don't like that. There'd be a chance that they would turn a corner and see somebody sticking a needle in their arm, and people don't like that. And then when the medically supervised injecting centre helped to reduce that level of distress, people were very grateful. So it's not at all surprising that it has such strong support from residents and local business. And when we look at the international literature on this subject, we find the same thing, generally speaking, almost all over the world, that local residents and local business are very strong supporters.
But it's not just a means of containing the problem and diverting it. It's not just a means of sort of removing the problem from the public eye and those distressing images. You turn a corner, someone's injecting in a laneway or something. I think what's most important is the fact that Bob Carr mentioned this on his interview with John Fain a couple of weeks back, that there were paramedics on hand, that there were counsellors, and in the mould of that Portuguese drug dissuasion committee you were talking about before, who could sort of act as sort of counsellors or mentors or monitors to the individual's drug use.
Yes, that's a very important part of it, that these people aren't just given a room and told, go on and inject. They're also offered help and assistance. And the kind of people who end up in medically supervised injecting centres in Sydney and around the world tend to be a subset of the drug injecting population. They are even more socially and economically disadvantaged than other injecting drug users. They have more severe physical health and more severe mental health problems than other drug users. So they're a particularly vulnerable, damaged subset of the general population. And I was very moved I went to some of the medically supervised injecting centres in Switzerland, and it's very moving to see how they're offered assistance. Of course, they don't have to take it, but they're also offered a referral for treatment for sexually transmitted infections, or if they have visa problems, or so they're given offers of wide assistance. One place I went into in Bern in Switzerland, the federal capital of Switzerland, they had a section of the medically supervised injecting centre where they made snacks and small meals which they sold to drug users in the centre, and they employed drug users and trained them to make coffee and toast and heat up soup and handle small change, there's also a message there saying, listen, buddy, you're a member of this community and maybe you weren't functioning so well yesterday, but maybe you can get a job in a kitchen and in a restaurant, and tomorrow things might change for you. And that also, if they wanted to, they could have a shower and wash their clothes and shampoo their hair, and then in an hour or two they'd be feeling good again about themselves. So it's very important to have that wider social aspect to these centres. They're not just places for injecting. People do get referred to drug treatment, to primary health care, to social services, to legal services, accommodation services. And drug problems aren't just drug problems. Very often they have a lot of other manifestations apart from just the drug problem.
Hi, I was just wondering what sort of thoughts you have on things like the online drug marketplaces like Silk Road in terms of both harm minimisation and the challenges they throw up for prohibition and indeed drug reform.
Well, that's a great question, and we're not supposed to say this in public, but if we're thinking about drug markets and how and the inevitability of drug markets. Whenever there's a demand, there's always going to be a supply. One of the really nasty aspects of drug markets under prohibition is that they're very violent. Not always violent, but they're often enough pretty violent. I mean, you've had almost 40 deaths in this city in the last decade in association with the methamphetamine market. So they're pretty violent. And if you think about it, one of the benefits, and there may be disadvantages about distributing drugs through the internet, but certainly one of the benefits is that it gets rid of all that violence. So I think personally that there are things that need to be explored about that. I don't like the fact that there's a lack of opportunity to regulate what's going on and to make sure that the drugs are safe and of a particular concentration and that people know what's in them. I think that's as important for drugs as it is for anything else. So I don't see how you can provide consumer protection through a market that has no regulation. So I'm not happy about all aspects of it, but at least it's not violent.
You mentioned earlier that the people or the people that the injecting rooms are servicing or helping are a specific subset of the drug abusing community. What percentage of that do they make up of the large community? Like, how many people are they actually helping?
Well, that's a good question too, and it's a sort of how long's a piece of string kind of question, because it depends on how much the state is willing to fund these centres. In Switzerland, for example, in the Netherlands, in cities that have really serious drug problems, they have 2 or 3 drug centres in the one city, and each centre will be open for 6 or 8 hours, so there's one open virtually around the clock somewhere around the city. And of course, when they provide 24-hour cover, they can handle a lot more people than the centre in Sydney, which is open for about 8 or 10 hours a day, 7 days a week. So it really depends on how big the centre is, how many staff it's got, and how many hours a day it's open. The one in Sydney, I think, has about 300, 400 visits a day. Some of those people come back for second helpings on the same day, so it has more visits than the number of individuals. The one in Vancouver has many more than that, has about 700, I think, a day. And they've only got the one in the whole of the Americas, and that's in Vancouver. So really depends on how much the state is prepared to back these centres. The other thing that's been very noticeable around the world, that the centre in Sydney and the centre in Vancouver faced vociferous and relentless opposition from minority groups, and they certainly undermined those centres. The ones in Europe haven't had to contend with that kind of vehement opposition, and it's allowed them much more flexibility and much more made it much easier to operate those centres. So it also depends on whether your centre is supported by the community or whether it's undermined by sections of that community.
One more, yeah.
The opponents of any sort of drug law reform would say that that if there was any easing of the prohibitions on availability of drugs, that everybody would be doing it. My personal feeling is that the mere illegality of drugs is actually quite a potent attractant for drug use. Have you got anything to say about what makes people take up drug use in a professional sense?
Well, that's also an important question, and the opponents of drug law reform, the supporters of the war on drugs, really bring this question always back to one question for them: and only one question, that is how many people are using drugs. Now that might be an important question, but for me, a much more important set of questions is how many people are dying, how many people are getting terrible diseases, how much crime is there, how much corruption is there. And for me, I would be prepared to put up with a reduction, with an increase in drug use if we had a reduction in death, disease, crime and corruption. So I don't want to, in answering your question, I don't want you to get the impression that for me it's only about drug use. I think those other things are even more important. Do we know how much drug use goes on when these drugs are legal? Look, it doesn't seem to make all that much difference, surprisingly. What does seem to happen is that what drug use occurs is much more damaging when there's a draconian, very repressive environment. And there are many, many examples where we have seen the forms of drugs that are available become much more dangerous the more severe the drug law enforcement, the more intense the drug law enforcement. So, for example, we saw in Asia a famous study published in 1976 by an American psychiatrist talked about the pro-heroin effects of anti-opium policies. And what Dr. Westermeyer observed in Laos, Hong Kong and in Thailand was that in the 10 years following the prohibition of opium smoking disappeared in those countries but was replaced by heroin injecting. The opium smoking had been by elderly men, and I think I can say this with impunity, that elderly men in villages and maybe elsewhere aren't all that useful, and so if they were sitting in the corner getting stoned, smoking opium, they'd get a bit constipated, they wouldn't eat much, they were using too much of the family savings maybe, but it wasn't great, but it wasn't terrible. But heroin injecting then in young and sexually active men meant that the situation was very different. And here we had the conditions created for an HIV epidemic in a part of the world that accounts for half of the world's population. So there are many occasions now, there are many examples from around the world where draconian drug policies produce a more dangerous drug market. And the reason for that is that if I'm going to traffic drugs and you make the penalties for those drugs more severe, then I'm going to make the drugs that I sell in a more and more concentrated form so as to maximise my chances of not getting caught. And the more concentrated the forms of drugs, the higher the chance that someone could make a little error in their dosing to themselves and have a fatal overdose. So we see many examples where draconian drug policies have caused more dangerous drugs to drive out less dangerous drugs. So where drugs have been legal, 100 years or so ago, there was more drug use than after the drugs became illegal. But the drug use, did it really matter that a lot of people 100 years ago in Victoria were taking edible opium and getting a bit constipated? Well, I don't think so. But it certainly matters when a smaller number of people are injecting heroin and having lots of overdoses. We have 400 overdoses a year, fatal overdoses from heroin in young people a year in Australia. I think that's a scandal. So it's like a 747 full of young Australians crashing every year and killing everyone on board through heroin overdose. Big problem. Yet you can go from 1 year to the next without this discussion being raised. And this is one of the issues that the Medically Supervised Injecting Centre in Melbourne would address by having these centres close to areas where there are lots of overdoses.
We're going to have to wind it up, which is such a pity. There's so many more things I know everybody probably love to talk to you about. Alex, thanks so very, very much for coming and being our guest on the Fifth Estate at the Wheeler Centre.
Thank you.
Thank you.